Good afternoon, everyone, and welcome. My name is Melissa Mueller, and I am DWDC's Program Specialist. I am joined today by my colleagues, Kelsey Goforth, Director of Programs, and Amanda Coventry-Barrage, Program Coordinator. Before we begin, I want to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada is a traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, and Inuit and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We invite and encourage you to do your own research regarding the various treaties, in particular the land in which you are meeting with us today. And I'm thrilled today to welcome you to the third session of Dying with Dignity Canada's Learning Centre. Through this series, we aim to provide comprehensive information on several topics related to death and dying. And by attending the 5 sessions over the next month, you should gain a thorough understanding of the issues that matter to you. If you haven't done so already, all sessions and their registration links can be found on our website. And we will be putting in a link for the next session on Grief 101 in the webinar chat. And before I welcome today's presenter, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunity to submit questions. To do so, please type your questions in the question bar on the Zoom side panel, and we'll read out loud for you at the end. And please try to keep your questions as concise and clear as possible. And while we are going to try to get to as many viewer questions as possible, unfortunately, we may not be able to get to everyone. And so if you have an outstanding question following the webinar or questions that are quite personal in nature, please contact us at support@dyingwithdignity.ca, and we will follow up with you individually. And we will also be sending a post-webinar survey that will pop up on your screen after the webinar, and it will give you the opportunity to share your feedback. And this session will be recorded, so you will be able to watch it again later, so there's no need to take notes if you like. And now I'd like to introduce today's speaker. So joining us today is Dr. Jyothi Jayaraman. Dr. Jayaraman is a palliative care physician who has been a MAID provider and assessor since 2016. She is a clinical assistant professor in the Department of Family Practice and an associate member in the Department of Medicine in the Division of Palliative Care at the University of British Columbia in Vancouver, BC. And I will now pass it over to Amanda to get us started today.
Okay, thank you so much, Melissa, for the introduction, and thank you, Jyothi, for sitting with us today. Now, of course, this discussion is going to be all about palliative care. So, Jyothi, let's just jump right into it. What is palliative care?
So, Amanda, before I jump in, I should acknowledge that here in BC, I'm on the land which, as you know, is the unceded territory of the Coast Salish people, and that includes the Musqueam, the Squamish, and the Tsleil-Waututh as well. And thank you so much, DWD, for having me. I think some of you know palliative care is my passion, so I love talking about it. So when you ask what is palliative care, many of our listeners may not know that the word palliative care was in fact coined by a Canadian, Dr. Balfour Mount, in 1974 at McGill. And at that time, some people may have read Elizabeth Kubler-Ross, who had written some good books about dying, because really at that time, dying was behind closed doors, and she opened up that to many people. And so Balfour Mount was a urologist, nothing to do really, you would think, with death and dying. He got interested. And the founder of the modern hospice movement is Dame Cicely Saunders, and she was British. She was in the UK. She had founded the St. Christopher's Hospice in the late 60s. So he went there, he got into it really, and came back and started a palliative care program. So when you ask what is palliative care, I would say really that it's whole person care. And it means that we try to address not just the physical concerns, but spiritual, psychological concerns, and not just of the patient, but of the family, of friends as well, who are close to this person. Ideally, I think medicine should be practiced like that, but we know that's not how it works. So palliative care is restricted to those who have been identified with a life-limiting, life-ending, life-threatening illness. And just to expand, the original movement was very much focused on that terminal period, on the life-ending time, that people wish to die with dignity, with no suffering, that was the focus. But over the last maybe 5 to 10 years, and maybe even more in the last 5 to 6 years, palliative care has expanded. We now are also involved in helping people who are not at that very end of life, but even earlier in the trajectory towards death. So could be a couple of years before. So that, I think we'll stop there, because the WHO's definition is something that people may have heard of, and it's pretty much what I said, but I'm just going to quote it. It is: palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. And so I will add, because this is where the controversy always is between palliative care and MAID, so I think I should mention that is the original definition. But there are certain clauses that have been added, and there's a reason, I think, for it. But one of the ones that's the most controversial is that it affirms life, not this one, this one's good. Life and affirms life and regards dying as a normal process. But the next one intends neither to hasten nor postpone death. And that particular clause has been used by some in the palliative care field to keep MAID out of hospices. And I'm sure we'll get into all this, but as part of what is palliative care, there is this distinction that here, but according to some people, that it neither hastens death nor postpones death.
Okay, thank you for that introduction. I know that trying to answer such an open-ended question like that could take an entire semester's worth, but we'll just ask a little bit about yourself as well. Why did you choose to specialize in palliative care? What's your passion behind it?
So I trained in India, and I actually practiced rural medicine, and I did a lot of things which ultimately was difficult for me to do, because there's a lot of suffering in rural India and, providing primary care. And my second passion was biochemistry. So I actually moved out of clinical medicine, and I was a biochemist. And then when we came to Canada, I was actually working in a cancer research laboratory, planning to start a PhD. At that point, a good friend of mine got ovarian cancer. And when, unfortunately, she didn't respond to treatment, and we're talking in the 90s. And at that time, she told me, when she knew that her end was approaching, she said, I hope I get a palliative care bed. I had not heard of palliative care at that time, in the 90s. We had always been exposed to death and dying, but in a way of, we've got to fight this. We've got to do everything possible to stop this. So the idea that there was this embracing, not death, but embracing this final journey was very novel to me, and it was very attractive. And so I went back to clinical medicine, and I practiced palliative care as a family doctor for a while, and then I did my fellowship in palliative care. And what attracted me was really this idea that we are mortal, we are all going to die, and how we die, we can influence that, and that I could be part of that journey. That very important final journey was very deeply special to me.
I can tell from just the way you speak about it that this is truly a passion, and I really appreciate you for sharing that with us. So let's transition a little bit to, again, some of the basic questions on palliative care. Where can someone like myself, or any of our supporters, where can I access palliative care?
And this is something that many people would want to know. The first thing that it's important to know is that healthcare is provincial. It's not federal. So what I say would apply to BC, and then not even to BC, because there are health authorities. And so within each health authority, services are provided in a unique way. Although there's a globe, pan-Canadian, yes, everybody is entitled to healthcare. What that healthcare looks like is actually different in different places. So if one is struck down by an illness, unfortunately, it is pretty much, unless you advocate for it yourself, otherwise it's sort of provider dependent. So let's say you are, not you, I will not say you. If one is a cancer patient and the oncologist feels that there's no further curative treatment, but there's palliative, but no further curative, and the person has needs, pain or nausea or some other symptom management, many oncologists and cancer centers are linked with the pain and symptom management clinics staffed by palliative care teams. So they are directly connected. So that can be there. Then there is also, like in Vancouver, we are lucky, we have an ambulatory clinic which deals with patients from the community who may have high care needs. It's not very well known, but it is available. So a family doctor who feels out of their depth can say, can I refer to this clinic? Unfortunately, there are some reasons, you can't just refer. So that is one way of getting some palliative care input. Other ways are sometimes one is admitted in hospital with some kind of crisis, and there are palliative care teams in hospitals, which the most responsible provider can contact and ask for a consult. And then really towards the end stage, the provider can recognize that, yes, this person's prognosis is less than 6 months. And in BC and hopefully in other parts of Canada, there are programs. So there's the BC Palliative Care Benefit Program, and you can be registered with that. And that means the community nursing and other, health support workers, hospice physicians can get involved in your care. So basically, the eligibility really depends on the stage of the illness, though there are times when you may benefit from it even when one is not actually dying.
Okay, thank you. Now, I want to ask, what is, and I ask this almost from an outsider perspective, but what is the difference between hospice care and palliative care?
And that's an important distinction, because I think in the past, palliative care was almost equated with hospice care. And so first of all, what is hospice care? Hospice care, again, I have to tell you that there's different definitions and different things happen in different hospices. And for instance, those who are familiar with the American program, hospice, there aren't that many standalone hospices. Here in Vancouver, we have freestanding structures, which are called hospices. Most of them have about 10 beds, not more than that. And the philosophy of care in hospice is that there is no life prolongation, that the person who is admitted there understands that they are here because they are dying and their care needs are more than can be met in a different setting, like say at home, or that they are too frail, maybe they're bedbound, or maybe their symptoms are very, unmanageable at home. So one, that there is no life prolongation. What does that mean in practice? It means that, for instance, if you needed intravenous medications, that's not an option, but we do a lot with subcutaneous and oral routes. And then if you need investigations, so x-rays and blood work, this is not traditionally done here. The other thing is that most hospices, and this keeps changing, but most hospices would say that your prognosis should be less than 3 months. So you're definitely on the, you are dying, and that's why you're in the hospice. Now, palliative care, on the other hand, that's not how it is. Palliative care can come in at different stages. So you can have someone who has still on chemotherapy, still receiving radiation. And having said that, in hospice, sometimes we have people who are taking oral chemo, or they develop some acute problem where we know that radiation will help, we'll call, and we can transfer them for radiation. So it's not like hospice will not do anything. If it's required for comfort, we too can access it, but it's not routine. So, but palliative care can extend to patients who are not dying, who are not in the last stages of dying. It can be a year, 2 years, especially when we think of heart failure, end stage respiratory problems. So people who need symptom management and who don't have any curative options, because palliative chemotherapy, palliative radiation, these are still palliative, but the palliative care team can be involved in such patients as well. So I would say the biggest distinction is it's not, and hospice is patients who are in hospice. Palliative care can be delivered anywhere. It can be in an acute tertiary care hospital. It can be in long-term care. So palliative care happens there too. It can be in homes. So it can be in a standalone clinic. So palliative care extends over a much larger number of people, can start much earlier in the trajectory of illness, while hospice is a very specific, in Vancouver and in BC in general, it's in a place. Though home hospice is also where, patients who are at home and who are dying can access it as well. But generally, when we talk about hospice, we're talking about this sort of standalone structure. I don't know if that makes sense.
That does, actually. I feel like that's a very clear sort of guidance you've gave between the separation of the two. But for my next question, I want to dive a little bit deeper into palliative care. And I want to ask specifically, who is involved in a palliative care team? Who provides the care? What are their roles?
So ideally, I am still an idealist, and I have had the privilege of working with fantastic teams. So a good palliative care team has a clinician, could be a nurse practitioner, could be a physician, has palliative care nurses, has social worker, has occupational therapist, a physiotherapist, a dietitian, a music therapist, a spiritual counselor. So in the ideal team, and I may have forgotten some, but in an ideal team, this is what, and believe me, we did have this team. It is where, and why? Because the palliative care approach is we're looking at the whole person. So the clinicians can tackle, the physician or the nurse practitioner can tackle the physical symptoms. There's pain, there's dyspnea, there's nausea. What should we do? How do we manage this? The social worker would be the one who would say, are there things, for instance, financial? Some people get struck down so suddenly, they have made no arrangements. The social worker is extremely helpful with that. The other thing is there could be in very complicated family dynamics. There could be lost loved ones, meaning you've lost touch, there's been estrangement. This is what the social worker can facilitate. And the occupational therapist and the physiotherapist actually provide that sense of, yes, you're ill, but these are the things you still can do. And the occupational therapist can say, when you're being discharged at home, these are the things we have to make sure that you are safe. We need these bars, or basically, how do we keep you comfortable and safe, even though you're not well? The music therapist, I think everybody knows, it's wonderful. They come and they play for you. Sometimes they help patients actually write songs. We've had music therapists who have, and now with the beautiful, you can download anything. So different languages, and people can listen to music of what they've heard before. And very often people want to go back to when they were young and they heard some songs. And so the spiritual counselor, again, we try to have non-denominational spiritual counselors, and it doesn't matter if one is an atheist. When one is approaching death, there are questions that can sometimes arise. And so I think, and the dietitian, again, very important, because as one gets very ill, there's this disconnect. One feels one should be eating more, but one doesn't have an appetite. One sees oneself losing weight, and it's frightening. There's a voice in your head saying you're getting so thin. All your loved ones are telling you, come on, people are bringing special stuff. You just can't eat. And so it's important to get that guidance from the nutritionist who will tell you, get the biggest bang for the buck, meaning eat this is calorie rich, or don't just, and especially in these days when people are very health conscious, everybody perhaps is juicing more and doing these things, but it may not be the best thing for someone who's dying. So I think, these are the roles. More people are familiar perhaps with the palliative care physician or palliative care nurses who do such amazing hands-on work, but these are all the different roles that are important in a good team.
Thank you. I think that's pretty clear as well with your answer there. And I think it's quite special in palliative care that, again, as you mentioned, it's about looking at the person from a whole, about providing a more full service, a whole service. So again, I think that really makes a lot of sense. So I think I want to ask a little bit, we touched a little bit about this on our first question, but how would you say palliative care is different from other streams of medicine? So you mentioned again that yes, we do approach everything from a whole and look again at the patient as a whole, but if you could elaborate a little bit more on why you think or how you think that palliative care is different from other streams.
So I think, first of all, so the whole person approach, I think, is vital because, I mean, I'm a family doctor. So I have worked in places where, look, if you come in with a backache, apart from me having to make sure that there's nothing serious going on, you actually just lifted something, and I have 10 minutes or 15 minutes with you, my focus is going to be on that, just how to fix the backache, go to this, do this, and here's that, and off you go. Similarly, I think with different specialties, what can happen is its time is limited. And so the focus is very clearly on, you come in with a heart murmur, or you have chest pain, and the focus is on that. What happens though is when you're being seen by, say, some specialists, and this can happen even with cancer, the whole focus has been on that cancer, and somewhere along the way, a lot of things start getting missed. And as the situation becomes more dire, the person feels like, I'm doing all these things, but I'm still suffering. Something is going on, not necessarily physically. What the palliative care consult does, and this happens every time you have a palliative care consult, or it should, is we start at the beginning of the journey. Just because, so if you take cancer as an example, when did you get sick? What has happened? And we build it up. And now we ask you, what is it that's troubling you? It could be, yes, I'm dying. I don't want to die. But it could also be, I'm so worried about my children, or I'm worried about my parents, or what am I going to do for money? So there are other things. My housing situation. Now, some of this may be addressed in other ways, but I think palliative care does that. And that's what I would say, expanding on the whole person. We're looking at more than a symptom. The other thing which I feel distinguishes palliative care is it's preventative. It is anticipatory. And by that, I mean, we know, because we have walked this journey so many times, we know the way ahead. And so if you have a CT scan, which shows, for example, there are lymph nodes here, there's something else there, it means something different to me, because I look at it and I say, wait a minute, these lymph nodes are clustered around this part of the bowel. Could it have an impact later on? And so, or the bowel is tethered here. Could that lead to a bowel obstruction? So anticipatory care means you can try to say what lies ahead. What is it that I need to be careful about? And I think that's what palliative care does. It is anticipatory care. And the third thing I think, which is very important, is palliative care. The clinicians are experienced with transitions. And by that, I mean, how do you move from being, I'm going to beat this thing. I'm ill, but I'm going to beat this. I'm going to get better. I'm going to get better until, no, you're not. And how do we make that switch? And because of our training in medicine, modern medicine, it is, I would say, not even modern medicine. You go back maybe to Greek times. It has always been cure, cure, cure. And even today, I think physicians are uncomfortable, really uncomfortable about talking about death and dying. And why is it important? Because there's so much that somebody may need to do if they knew. We often get people who have no idea that they have 3 months left or 6 months left. Clinicians are scared to prognosticate, but it's so important. You always, there's a caveat. You say, I could be horribly wrong, and I hope I am. I hope 1 year from now, you're laughing and saying, hey, Dr. Jyothi, you told me I'd be dead in 6 months. Look at me. We want that. But we want you to know that there is a high possibility that you may not be around, so that you can do things, whether it is transitioning away. For example, leukemia patients are so caught up in transfusions and blood work and transfusions and blood work. And slowly you're noticing that the transfusion is now every week. And at that point, we know that things are not going well. There is a bucket, it's leaking, you're going on pouring it in, but it's just leaking right out. How do you try and move away from that? Sometimes it's a period when you're doing the blood work and you're doing the blood transfusions, but you're also getting this input saying, things are changing. And I think palliative care clinicians, nurses, doctors, everybody in the team is comfortable because we have been there. And the last thing is, I feel we bring hope. I think what we do, which is a funny thing to say, because what do you mean hope when someone is dying? But actually what we're saying is all is not lost. Just because the end seems near, it doesn't mean that life is over. You can live well until you die, and we are here to support you through that. So yeah, I think I could just keep going on and on. You will have to stop me.
Well, I don't need to actually. You actually perfectly dived into my next question, which was, and you can feel free to add anything that you feel you may have missed, but I wanted to ask specifically, how is a palliative care team especially equipped to work with ill patients? So you mentioned that, again, you're skilled in transition, it's anticipatory care. So again, if you have anything else you'd like to add on that, or if you want to maybe give a bit more detail on that, but again, how are they specially equipped to work with seriously ill patients?
One of the things that I realized, because I had been away from clinical medicine and I came back, and what was it that attracted me? And I came from, biochemistry. I love biochemistry, and it's all molecules and they behave, this way and that way. And it's very different from human dynamics. But I think just that acknowledgement that we're not fighting anymore. It's not a surrender, but that it is a calm acknowledgement that, look, we don't know when the end is, but it is nearer than not. And so that, I feel, brings to the entire team, all the team members in a palliative care team have that approach. Now it's your comfort that matters, the patient. We're not interested in anything else. So we're able to say, maybe it's a mindset, it's an approach more than anything else. So it's a shift in focus, it's how we frame it. It's the same person with the same illness, but we've shifted it so that now we are saying, what is most important to you? If you only have 3 months left, how do you want to spend it? And that shift is what I think the palliative care team can bring better, because for us, it's not a sense of failure. And I really want to emphasize that, because we as clinicians are so hate failure. And we should normally, because we don't want to fail our patients. We want to do our best for you. But what if you now say, doing our best is providing comfort, not avoiding death? While for everyone else, it is really avoiding death. And I have failed you. If the cancer came back, I failed you. If my surgery was unsuccessful, I failed you. But we don't feel like that. For us, the failure would be if you're still suffering. How do I make you better? But I'm not trying to tackle something which I can't tackle, which is death. So I think that approach, it really seems to me, it distinguishes us, and why there's a sense of peace. And almost when someone comes in, after a while, they realize that, okay, I can stop running. And I think that ability to create that transition, make a safe space, and as I said, add that hope, comes from, I feel, the palliative care.
Thank you, Jyothi. I mean, again, just very insightful, very informative. And again, I really love the message that you bring, which is it's about hope and it's about reducing suffering. And again, moving away from being cure oriented into more about the whole patient and being patient oriented. I think that was a sort of beautiful way that you had phrased it. So I want to talk a little bit more. We're going to transition here into receiving palliative care. So now I know about palliative care. I know who's on the team. I know sort of their perspective. I know how they're specially equipped. But how do you determine if someone is eligible for palliative care?
And so we touched on that briefly, and but we'll just expand on that. So if we start from the closest to death, so let's talk about having, again, remember, I'm speaking specifically of my health authority, because there are differences in health authorities. So did I mention about when I said the palliative care team, I forgot one important member.
Sure.
And that
Let's
is
go
the
right back
family.
to it. Yeah.
Let's just go
let's
back. I
talk
just want
about,
to
yeah,
mention that because it's important.
of
It's the
course.
family physician or the nurse practitioner. It's the primary care provider. A lot of different palliative care programs have the family doctor or the nurse practitioner, the primary care provider at the center, and everyone else sort of flies in and out. So I must mention that, and just remember that and put that away. So when we talk about who is eligible, so we start with who can come into a hospice. Let's start there. To a hospice, it would be in general less than 3 months prognosis, accepting of the philosophy of care, which is that you don't, there is no life prolongation, even though there are small, somebody's on oral chemo and etc. But basically that is, you need to have that. So underlying the prognosis is 3 months, accepting of the philosophy of care, and then your care needs. You can't, just because you have less than 3 months and you have accepting philosophy of care, doesn't mean that you need us, because it's a very specialized team and it's a small, as I said, it's usually a beautiful setting, just about 10 patients. There's a nice patient to nurse ratio. The doctors round every single day, see everybody. So it's fairly high, a lot of attention being paid. So there aren't enough beds. So there is a sort of, you need us to come into hospice. Then let's talk about what can be delivered at home. So when do you enroll into a home hospice program? And that is usually a prognosis of 6 months. At the end of 6 months, if you're still there, they'll extend it. You can apply again. And what are the benefits of that? There's medications are covered, visits by the nurse, some home support, all that can happen if you're part of this benefits. But your prognosis has to be less than 6 months. And again, you need to have some care needs, but not as many. If usually the referral is made, say, by the oncologist, who recognizes that now this patient, there's no more curative treatment. Maybe there's still some ongoing palliative chemo, but that would be, they would make, it's a formal referral saying this person is on palliative care benefits and would benefit from being enrolled in the home hospice program. So there, usually the prognosis is less than 6 months. Beyond that, though, let's say there's somebody who's in the cancer agency receiving cancer chemotherapy, but just has some difficult to manage symptoms. Often they will be referred to the pain and symptom management clinic, which is really the palliative care clinic. They may have years to live. Patients, for example, with breast cancer can have all kinds of things happen to them, but continue on for a long time. They develop a long-standing relationship there. The other thing is there are standalone palliative care heart health clinics. I think there are some for nephrology, not enough in neurology, which I really feel should happen, but there isn't, because with Parkinson's, ALS, yes, but there are other illnesses where I really feel it should be there. So eligibility for funded programs is sort of, there is a gatekeeper, but asking for a consult from when a patient is admitted in hospital it doesn't have to be someone who's end of life. It just has to be someone who's got a life-limiting, life-threatening illness and has symptom management needs. The family doctor, I don't know in Ontario, for example, what resources are there. Here in Vancouver, the family doctor can ask for help. They often are comfortable with some initial like pain management, little bit. But again, our medical school training is not adequate. And also a family doctor is so busy, everything is dumped on them, So they don't have the time that they need. Many still do a wonderful job, but it's hard. But they can make a referral as well. So eligibility depends on who's looking after you. And I would say that if you've been told, for the audience who's listening, if you've been told that you have a life-limiting, it's end-stage heart failure or it's end-stage lung failure, if you're being treated for cancers, neurology, Parkinson's and illnesses like that, ask the primary care provider, whoever that is, not just primary, it could be the specialist. Ask them, do you think I or the loved one you're advocating for would benefit from a palliative care consult? Because unfortunately, you can't self-refer. We don't have, we can't just say, oh, I'd love to see a palliative care doctor. Can I go see them right now? No, that's not, someone has to send you there.
Okay, and actually that's a great point you brought up. So I actually want to ask, my next question is about misconceptions about palliative care. And you've kind of nailed one of them there, where you can't just make a independent request and say, I'd love for palliative care. So could you talk a little bit about the misconceptions around palliative care?
I would start by the greatest one. There is a myth that palliative care is no care. There is really, and in fact, I think that the WHO definition that I mentioned, where there's a clause about not hastening death, I think that came about because really palliative care struggled with this image that if you go to palliative care, it means that's it. There's going to be nothing. You've been abandoned. You've just been left to die. And people still use that. And so we still have people who are referred to us and they feel like, oh, the specialist doesn't care for me anymore. My oncologist is not interested in me anymore. So they've sent me to you. So palliative care is equated with no care. It is not no care at all. There is a lot of care. In fact, I would say there is extensive care, but not the same kind of care that you were used to. I think that is one of the biggest myths. In terms of not having self-referral, really what I meant to say is you can ask for it. It's not that you can't ask for it, you can, but somebody may tell you, oh, you're not there yet. We keep hearing that. People are told palliative care, because even among clinicians, there is this myth that palliative care, maybe that's a second myth, that palliative care is only meant for those who are actively dying. And I often, without being facetious, I often say that for many people, palliative care is candles and kumbaya, that we're just holding hands and singing and that's it, nothing else. But it's not, it's very active care. We can really do a lot with pain management and other things. And as I said, we often work with specialists. So it could be if you have a bowel obstruction, we could ask for a general surgeon to help us out, or radiation for metastases in the bone. So there are things that palliative care does, which so it's not no care. It's not meant only for the end of life, which those are the two things which I think are most important. And then, this is the hardest one for me to say because I'm speaking to a DWD community. I feel I should say it. It is that today, I think for many people, palliative care clinicians oppose MAID. I think is this a myth? Is this a myth that palliative care clinicians oppose MAID? And I say it is a myth, and I'll tell you why. Because I feel that there are a few people who are very vocal and articulate, and they have really stolen the agenda in a way and made it about, oh, we in palliative care oppose MAID. So it means if you want palliative care in a hospice, we're not going to allow you to come in here if you want MAID. But that is a very few people. I'm so fortunate. I work in hospices where MAID is allowed. And in fact, there are MAID palliative care physicians who don't provide, but who assess. There are others. I even had this amazing experience where we have to talk about that too, forced transfers, because that's palliative care, and we will talk about that. But there was a person who was in a religious facility who needed to be transferred out for MAID. And the treating physician, who was a palliative care physician, was so moved by that, he wanted to do what was right. And he accompanied the patient in the transport because he wanted to ensure that that person was well cared for till they were safely handed over to our team who received that patient. So and they suffer a lot of moral distress. So palliative care physicians, it is not, we're all in one box where all of us oppose MAID. No, I would say the majority are either silently supportive, but they work in environments where if you need a job, if you want that job and you're told by the division head that you can't do this, or in the facility you can't, what do? So you can't just say, I'll quit the job. I mean, that's not something everybody can do. But so the myth that palliative care is opposed to MAID, or that it is not, is there a myth that palliative care and MAID cannot be side by side? I mean, in the early years, I fought and said, to me, I still think of MAID as an extension of palliative care. It's one more thing in my toolbox. When I, the palliative care physician, have done everything that I can to try to end your suffering, and you tell me, no, Dr. Jyothi, this is not working. I just want to die. I am so thankful that I can say, yes, you can. Of course you can. I mean, we are lucky we have this law, you can. So I fought a bit to say we should think of this as an extension, but okay, for some people, it's a very sensitive subject. So what I would like to just say, it's an end of life option, just as palliative care is. And so I would like to say that if people here think that palliative care and MAID are always, clashing with each other, that's not true. Many of us are supportive of MAID.
Well, thank you for that distinction, and for tying again palliative care providers and MAID providers or MAID assessors. We actually have an audience question that relates perfectly to this, and I want to ask you this just because we're on the topic. But in your experience, why do some people choose MAID even when they have access to palliative care? So I know that you mentioned one specific example, but perhaps you have some other options.
Yeah. So I have been truly astonished because, first of all, I have a privileged position because I am a palliative care physician, and I work in hospices, and I do provide palliative care to patients at home. And some of them have been my own family practice patients whom I've known for, a long time, and who then fall ill, and I've been with them through the whole journey, and then I've ended up being their provider. So I really looked after them for that whole time. So I've had a chance to look at them. Why do some people choose MAID? To me, the more interesting question has been, why do some people not? Because I honestly thought when MAID became legal, because I'd seen so much suffering that I thought, oh, so many people are just going to want this, but they don't. And this is why I feel palliative care is so crucial. So let's give you an example. Somebody who is quite ill and has cancer and has said, I'm the kind of person, I can tolerate pain, and now you've made it bearable. Palliative care has been excellent. But for me, really, I don't want to become bedbound. If I get bedbound, I'm going to call you and say, this is it. And then, to my surprise, they're admitted to hospice. And why are they in hospice? Because they are bedbound. But what has happened is either it is, all of us have different ideas about life and death and what comes after. And for many people, this life is so precious that there is maybe a song that they love, a smile that they look forward to. I had a patient who had planted fall bulbs, and she just wanted to live a little longer to see what would happen to her garden. We don't know. There are many reasons why every moment is so precious that they hold on. And if we can provide care with dignity, they realize that, so what if you're bedbound? The nurse who changes you, or the care aide who changes you, is so loving and so respectful. It's not a big deal you thought it was, because a little later, your loved one is coming, or the grandchild is coming, and that's so joyful. This becomes trivial. What is that? It isn't. So I think, so those are the patients who are eligible, who have signed the request, who have a waiver, and who choose not to go. But there are others. And I have many examples, and some of them have been physicians who know everything very well and who say no. These are people who say, I know what palliative care is, and I thank you for it, but that's not for me, because I want to die the way I am. I want to be able to say goodbye. I want to be able to choose the terms that I want to. I don't want to become, as I think the most frequent ones I hear is, I don't want to be dependent. I don't want to become bedbound and dependent on others. I want to die like this, or I want to die in my own home. So even though I have care, this is the reason why. Does that answer the question?
Yes, it does. Yeah. And
Okay.
you actually touched a little bit on why palliative care is so important and how it's able to minimize or trivialize some of the difficult things that people think about when they envision their end of life. And so again, I want to ask this question, and I think you've already spoken quite deep in thought on this, but what are some of the benefits to palliative care?
So yeah, we've addressed it quite a bit. I think the biggest one is this ability for a person who's dying to be able to, you get assistance in making that transition. So the biggest benefit is really reframing it, providing hope that it's not all doom and gloom, that there is some joy at the end of life, that if we can take care of some of the things that are troubling you, because if you think life is precious, then even those last 3 months, last 6 months, that's precious. So the benefits of palliative care are, we are now looking at the whole person. One of the things that I didn't mention is people think when you stop active treatment, it means that you are going to die sooner. But it's not like that. You're stopping the active treatment because it's not effective anymore. And often what's happening is it's making you sick, because this 5th line of chemo is not actually beneficial, but you feel ill, you don't feel good. So we actually see people who stop these things and actually feel better. I mean, there was an old study published in the New England Journal of Medicine, which wasn't looking for this, but found that in patients with lung cancer who were randomized to receiving palliative care and routine care, the ones who received palliative care lived a bit longer. And it was a shocking thing. And nobody has, really tried to replicate it, because that's not what it's about. But all of us have asked why. And it could be that when you're not on chemo, when you're not running around, you have time to just eat what you like, sit at home, your mind is at rest, you're looking after yourself, you're surrounded by love and joy. I don't know. But I think that is, for me, what palliative care can help you do is just take some of your fear away, just give you a little bit of hope and take some of that despair away.
Thank you. Yeah, absolutely. And again, I think we already touched very deeply on the subject, but I think again, your message of being able to take the fear away and of transitioning patients from fear to hope and to having sort of a plan, I think is very valuable. So I have one more specific question about palliative care, and this has been somewhat of a subject of confusion at times. So I want to talk about palliative sedation. Can you describe what that is and when it can be used or when it may be used?
So again, let me say that palliative sedation is used differently in different places. Some people have very strict protocols, and I think in Quebec they have to actually complete, because it's part of their whole, even their MAID is different from the rest of Canada, and so the palliative sedation is included there, and so it's different there. But again, across Canada, there might be differences. Even within units, there might be differences. But I'm only telling you what I have practiced and what I practice. And so palliative sedation is used when symptoms are not manageable by any other means. So palliative care tries its best, but it's not perfect. And even though we can help in most, I would say many, if not most cases and most symptoms, there are certain symptoms that are intractable. One of them is what we call terminal delirium, which is as death approaches, there can be sort of a confusion and the person is really distressed. And by then, they're practically not eating and drinking. That is one. Sometimes shortness of breath when there is advanced lung disease, usually malignant, but other reasons too. Shortness of breath is not easy to palliate. It is up to a certain stage, but sometimes at the very end, people can feel quite dyspneic, and it's not easy to control that. So sometimes pain can also be one of those things, though I would say that we have more ability to manage pain than not. But so when symptoms are unmanageable, palliative sedation, what does it do? It uses medications like midazolam, which is the same medication we use in MAID, which is like a Ativan. It's a sedating medication. And again, here, the way we use it is to put that person into a deep sleep. I actually tell people, once the patient is being sedated, I say, treat this like a sleeping baby. When you come in, don't try to wake them up and talk and say, hey, I'm here, because really we want them to sink into a nice deep sleep, and they are in that sleep until they die. Now, a couple of things we have to remember. One is that in that situation, that person is not eating and drinking, right? Because they are deeply sedated, so they're not eating and drinking. And usually, really, we're using it in patients who are already not eating and drinking. And death may occur in hours. Sometimes death may actually take as long as a week to occur, which can be a bit distressing for family. But even if you don't use palliative sedation, there are patients who practically don't eat and drink who continue to linger for a bit. They don't die immediately. People can last a long time without food and water. So palliative sedation is not something that a patient can ask for. Just can you just sedate me? It has to be shared. It has to be the treating clinician has to feel that, yes, this is an appropriate treatment for you at this stage. If the patient is awake, they can ask them. Sometimes what we do is, if we anticipate, especially if there are brain metastases and things, and especially before MAID, and even now, we would ask, if things got to such a pass that you're really uncomfortable, is it okay? Can I sedate you? And they may say yes, and we document that. We make sure the family is aware. Sometimes the patient is not able to consent, and unlike MAID, before we had the waiver of final consent, the substitute decision maker, we can discuss it with the family and say, we're really trying. And it's a hard conversation, because what we're trying to say is, from now on, even though, this person's not really going to be able to talk to you, but they are in such distress that most families are really, yes, please, can you just allow them to sleep? So palliative sedation is sedation so that the patient is in a deep sleep until the end of life, until they die.
All right. Thank you so much for that. Yes. Yeah. Thank you so much for that clarification. So that wraps up the formal part of this interview. And as always, I love to pass it on now to our audience Q&A session. So yes. I think let's dive right in here. We have our first question here. Are there certain guidelines about palliative care for people living with dementia?
That is a very good question. And so, are there actual guidelines? There is, there are dementia specific, yes, because one of the things would be, and this was something that was done here in Vancouver, actually, by one of the physicians involved was Romain Gallagher. The idea that pain can be manifest in a patient with dementia as just sort of acting out, they seem to be hitting out, they're behavioral issues, but in fact, it's untreated pain, unrecognized pain. So there are guidelines to assist patients, that assist clinicians to say, look, nowadays people would automatically think of that. It would be routine to say, oh, I think this person, rather than reach for an antipsychotic, they may be able to say, has this person got untreated pain? So the guidelines would be, if you ask me, can I point you to a specific one? Not off the top of my head, but there are guidelines which the focus would be on trying to make sure in patients who are unable to express themselves, what are the causes of suffering in these patients, and trying to address it. So those would be the main, I think the guidelines for dementia would be about that, how to assess suffering in a patient who is not able to speak for themselves.
Thank you for
that. And there are, I think, I can't tell you exactly, but I really do believe there are some guidelines. But if maybe later on, I can send it to you and you can send it, right, Amanda? Yeah.
Yes, thank you. Let's go to our next one, actually. So I like this question. So who determines if you need palliative care? At what stage in an illness does this usually happen? So I know you mentioned end stage, but could you talk a little bit more about that?
So who determines your primary treating physician? Whoever it is. So if you're with a cardiologist, with a respirologist, with a neurologist, with an oncologist, or your family doctor, they are the ones, or a geriatrician. So they are the ones who would tell you. But I would say you need to also, or you or your loved ones need to also be actively involved, because the key question is, do you have symptoms which are causing you suffering, which you feel are not being properly managed? Or do you get the feeling that everybody is going on saying, let's do this test, let's do that test for your dad, but they're not really looking at the whole person? And then you would say, you would ask a question, it's my dad, what do you think the prognosis is? And your treating clinician might get a little startled, but it's worth asking. So if they say that it's life-limiting, it's worth asking, do you think they benefit from a palliative care consult? So really right now, as I said, there's no standalone, it's not like, I can't emphasize how underfunded palliative care is. It is awful. We have no funding. There's no funding for hospice beds. There's not enough funding for home services. So we're very poorly funded. And so it's hard to get to see a palliative care physician, but it is through your primary care provider.
Thank you. And I just want to touch a little bit actually on what you mentioned again, if you're an advocate or if you're a loved one of a patient that may need to access palliative care or is eligible for palliative care. But I wanted to ask, is palliative care for the family too, or is it just focused on the patient specifically?
No, right from the beginning, it's always for the family too, because the whole person includes the loved ones. I mean, when we say family today, family is wide, it's extensive. It doesn't mean family by blood. It means your friends, your everybody, everyone who matters to you. And we try our best. Even I feel palliative care clinicians too try to bring that approach so that we often sit with the family's loved ones more sometimes than even with the person who is actually, the patient's loved ones, more than with the patient themselves, because they have so many concerns. So yes, it is up to a point. Again, do we have resources for everybody? No. If you're lucky enough to be in a setting where, there's a social worker, they spend so much time often with the families. Post-death grief, I don't think our grief services are very good. Bereavement support is not great, but that would be considered part of palliative care, but we're not, it should be. So let's say, yes, it should include everybody and often does, but perhaps practically it may not, because there are just no resources.
And then let's touch on resources actually. So our next question from our audience here is, and I mean, I understand that you're not a politician, but how do we make
Vote
palliative
for me.
care?
Yeah.
Yes, yeah. Yeah. So how do we make palliative care more available in rural and northern areas of Canada, areas where palliative care is just not as accessible for Canadians?
I think we need to advocate. How else do we do this? I feel like we need to advocate, because somehow, I don't know how much, do we attract donations? I'm not sure that we do, but it's money. It's money. Can we have standalone hospices? Can we have more clinicians? We are trying in medical school training. Just fundamentally, medical students need more training in palliative care. Do residents get enough training? Should it be made? I think it should be. Every single discipline in medicine, whether it's cardiology or whatever it is, they should have a rotation in palliative care. I can say that, but we don't actually have spaces for everyone to rotate through. But can we create more spaces? So I think every clinician who practices in the remote areas, they don't have to be palliative care specialists. For instance, in UBC, we have 3-month training spots. So you don't have to have the full formal, 1 or 2 year fellowship. You can do a 3 months. You could just to have, excuse me, that training. Because a lot of palliative care can actually be done with that training. The other thing is you need home supports, which you don't, it's so lacking. People want to die at home, but you don't have enough supports. And I don't know where the money goes or how the money is distributed, but our home supports, they're just awful. We don't have enough. So like you said, I'm not a politician and I don't know how to make sure that this happens, but we don't get enough funding for home support. Or the clinician piece, I think we can fix, because we have helplines doctors can call and ask us, and we can troubleshoot over the phone, and especially now with Zoom and stuff, we can. But on the ground, you need people to actually assist and help, and I don't think we have enough funds.
Absolutely. Absolutely. I quite agree. I wanted to ask, what are your thoughts on death doulas and their role in a palliative care team? We have that from one of our members of audience here.
I actually had the privilege of working with two death doulas. One was in a palliative care unit, and subsequently the patient, actually, this was before MAID, and she transferred home, and she was someone who was my patient, and I took her on after she went to the palliative care unit, and she really provided a sort of centering, a calmness for this particular patient. It was very important to her. And this patient had not been sort of part of mainstream medicine for a long time, had not accessed it. And so for her, there was some mistrust, and this was a comforting thing that doula was there and that we worked with the doula. and the other one was actually a MAID patient. And this patient was known to the medical community, but she was, she was full of art. She painted, she wrote poems, and the doula was able to go on that journey with her, share with her. And so that has really been my experience, that they can provide that. On the other hand, I would also say that really dying is, it's a bit like birth, in the sense that sometimes people just ease into death, but many times it's a team that, it needs to be present. So I would say that the death doula is part of the team, but you work with it. It depends on what the death doula is asking or advising. Sometimes if there's anything about, to avoid, say, don't take opioids, because it may, what are people saying? So what I've had the privilege of doing is working with doulas who integrate it beautifully. I mean, I welcome them, and I shared, they shared their poetry with me. But it's a limited experience, but obviously I think, I don't know what kind of training death doulas get as well. So I'm not sure about that, but if they can provide comfort, I'm all for it.
Thank you. Yes. And I mean, you can always, of course, just speak on your experience with death doulas. So it sounds like, again, with the one who was doing poetry and art, it sounds like she was able to add a lot of beauty to the sort of end of life process. So again, it's about that transition from fear and into hope, right? And focusing on the patient. So that was beautiful. Thank you. I want to ask a very important question that I've seen here from our audience members. So what to expect, how to prepare, or rather, what should you expect, or how should you expect, and how should you prepare for the transition of having healthy aging parents to ones that are going to need support and care? What are some of the things that our audience members could take away?
Is that palliative care?
For palliative care, yes, I know that's.
Right?
I know you're a family doctor,
and
so that's a very broad question.
Yeah. So that's a huge thing, isn't it? I would say start with advanced directives. I would start there. I would say, in a gentle way, understand from them, where are they? Have they thought about it? Are they even thinking about it? Because that, to me, is the most vital thing. Because if the parents are aging and they have a health crisis, and if they don't have, and they've never talked to you about advanced directives, you may miss an opportunity. So if someone is in their 90s and has always been fit and active and still hikes and does the grouse grind or whatever, but if you haven't talked to them, you may think, if they have like a catastrophic stroke, you'll be put into a thing of, I think we should put in a feeding tube because the stroke has compromised their swallowing, etc., and you're unprepared. So I would say, if you knew beforehand, and your mind may be, well, my dad was always a fighter, you just did the grouse grind 1 month ago, I think he'd want to live. Does he though? Ask them. So making sure that your parents have documented an advanced directive, to me, is the single most important takeaway message I would give. Because the other message I would give, and really CAMAP is having a session on dementia tomorrow, but it is that when dementia may be a slow illness, but there is a point when it often shifts into something more rapid, and don't take that moment of clarity for granted. Again, if you start noticing these changes, talk to open up communication. Find out, what do they want? What are their fears? Allow them to see there are options, including MAID. So I would say advanced directives, end of life choices for your parents, open up communication. If you have siblings, make sure that everybody's on board, because otherwise it gets really nasty. So make sure you can say, my dad spoke to me and he said he wanted ABC, no active interventions. And someone else says, no, wait a minute now. So everybody talk, communicate, and ask your parents what they want.
Thank you. I think, and again, I know that's a very broad question that you have to try and narrow down to sort of some nice bite-sized takeaways. So I thank you for that. Our next question is a bit more about sedation and end of life regarding palliative care. And so our audience member has asked, is it true that with about 10 to 15% of patients, that pain cannot be controlled at the end of life? Is that, for example, when palliative sedation would be used?
I would argue that 10 to 15 is far too high. I mean, I've been practicing palliative care for over 20 years, and I would not agree that, and as you all know, I'm a MAID provider and assessor, and I fully support, and I've always, well before even Sue Rodriguez, I have been thinking of MAID. Probably as soon as I came into palliative care, I always thought it should be a good end of life option. But no, I don't think so. I think pain, where there is confusion is sometimes when people may feel, I don't want to take opioids. I don't want to go on this. Or if the way it's managed, so if there's constipation or sedation with opioids, you need a little bit of skill to know how to manage that. So I would not say palliative sedation, in my experience, that's not the reason why I would say palliative sedation is used. It is very, very rare to use it for pain, according to me. I would say the two things that I've seen it most commonly used in, one is the terminal delirium, where there's so much confusion that I have seen. It's hard to manage because basically the management involves sedation. So either you're cycling in and out of, so you sedate them a bit, they seem calm, and then they wake up and they're confused again. So that's when you say, you know what, maybe continue sedation. The other one that in my personal experience has been dyspnea, real shortness of breath, even, the oxygen doesn't really help. It is difficult, I think, in my experience. So I would say not pain, but these are the two things that I would say are the most common for me. And I would say in general.
Yes, yeah, absolutely. Thank you. And you mentioned a little bit about patients, again, sort of refusing opioids or refusing a certain type of treatment. And so I kind of want to follow that line of thought here with our next question. Is there a requirement to try treatment before asking for palliative care? For example, do you have to try potentially curative treatments first?
No. So we have patients, for example, I've had a couple, especially breast cancer for some reason, and then they don't wish to go. They don't have, they wait, the tumor grows, it might even fungate, and they still don't wish for any kind of treatment. And absolutely, no, you don't have to go through treatment. The palliative care physician might tell you that if you did, as just like in MAID, we would say, you can get this treatment, this would help, that would help, but there's no requirement that you must have had this. If you are dying you have symptom management issues, yeah, you're eligible for palliative care.
Thank you for that clarification. And thank you again, everybody, for the audience for these great questions. We've got just a few more minutes here, so we're going to try and squeeze in as much as we can. I do apologize, Dr. Jyothi, but this question
I'm
here.
Okay. No, this is good. I'm all right. I don't have anything for the next little while, so we're good.
Okay. This question here is again a little bit more about sedation or painkillers. This audience member asks, I have heard that some people become fearful of becoming addicted to painkillers at the end of their life. How do you manage that fear? What do you tell patients who might be in that circumstance?
Living here in Vancouver, especially, we're very aware of this because there are people who have, fought long and hard to free themselves of addiction. And so when they are confronted with the way to manage this is to give you opioids, sometimes there's a real fear that this is something I didn't want to take, and now you're asking me to be on it again. One thing to remember is that when opioids are used to treat active pain, the chances of addiction are less. It's rare that the patient in severe pain is actually experiencing a high which would cause addiction. The other thing is that in palliative care, we're not using opioids for chronic pain, which is a different scenario completely. It has its role, but it's not as easy to do. At the end of life, it's a life-ending illness that you're on. So the addiction is when you're no longer in pain, when you don't need this anymore, but you still crave it. But this is not how it is. At the end of life, when you have pain, unfortunately, as the disease progresses, the pain gets worse. So you really do need increasing doses. So we are not going to reach a stage when, oh, you're pain-free and you still want this medication. So at the end of life, I would say that addiction issues, and this is how we explain it. And sometimes we have to explain it to the family as well. Oh, morphine, going to become a junkie. No, your son's not becoming a junkie. That's not what this is. This is required for pain relief. And addiction is not an issue at the end of life, because you're always going to be in pain without it. And so we give it to mitigate the pain, and the pain can increase. So we would increase it, and then you die. So it's not like we have to withdraw it because you've now got better. This is not getting better. That's how we would explain it. And I've had to do that many times.
Yes, thank you. And so we're going to wrap up with this final question here. And this one, again, is a bit more about sedation, or about when patients who are in palliative care might be in a deep sleep. This question is related to that. So our audience member asks, when individuals are in that deep sleep, can they hear your voice if you talk to them? And I know you mentioned that you don't want patients necessarily to be shook or to be woken by loved ones, but I think it's very hard, I think, for loved ones to just sort of sit in a room and not interact when it's someone that they love who's in palliative care. So if you could answer a little bit about that, if you could.
So what I advise is this. One is, let us presume they can hear us. And so let's be very quiet and respectful in that room. Sometimes arguments break out because people are sitting, not doing anything. Everybody's anxious and irritated. And I say, no, take that out. So this is a sleeping person. So let's do that. Let's make sure. The other thing I would say is you could music. Music to me is a wonderful gift for the person who's sleeping and for the family member who's waiting there. Shared music you both loved. So having something like that on gives, reading a book by their side, doing something quietly, sometimes just gently touching their hand a little bit, soft, a caress. So as I said, it's like having a baby sleeping. So how aware are they of your presence? Sometimes I think it's a murmuring, like a soft, gentle, it's a beloved voice. People are just softly whispering. Maybe that comforts. But I would emphasize that this sounds very harsh, but it is about the patient. It's not about you. So yes, it might be difficult for someone to just sit there, but if that patient needs that rest, because their brain is in a storm right now, and we need to really calm them. So for their comfort, if they need that quiet, then that's what we give them. However, we can have something like music, and if they seem restless, to reach out and to just sort of gently soothe them and say something softly. Yeah, that would work.
Thank you for that. All right, everybody, that is all the time we have for today. Jyothi, I want to thank you so much for taking the time to speak with us about palliative care. I know that I've been very informed during this webinar, and I certainly know actually that our audience members have been very informed and have enjoyed your remarks. I have one of our comments here that I'd like to shortlist here and say that Jyothi has been very informative and sensitive in her remarks. So that's just a little love note from one of our supporters. I want to encourage everybody that we do have our next session on the 31st of May on Grief 101. But again, I'd like to thank everybody today for joining in, for sending in your questions. And if again, there are any other questions you might have pending, or if you need some more one-on-one support, then I really encourage you to reach out to us at support@dyingwithdignity.ca. Again, Jyothi, thank you so much for sitting down with us today. Thank you for this discussion. Thank you for your stories. Thank you for your insight. This has been marvelous.
Oh, thank you so much. Thank you for giving me this opportunity. Thank you. And thank you to all the audience members as well.
Yes. All right, everybody, we're going to wrap it up here for today. Everybody, please enjoy the rest of your day. Stay happy and stay healthy, and take care. Bye-bye.